Hello guys, today it's 4th of September 2023 and today at Naraina Medical College and Research Center Panki, Kanpur, there was this pre-university exam of MBBS 2022 batch students, and this you are seeing is Anatomy Paper 2 Part 1. This exam was of 3 hours and the maximum marks allotted was 50 marks. This question paper pattern is according to the ABVMU, that is Atal Bihari Vajpayee Medical University. So question number 1 here is a clinical question with 3 subparts, 5 marks each, that together makes it 15 marks. The question is, a young male felt pain in the region of umbilicus. He also had nausea, temperature and increased pulse rate with leukocytosis. This means there was infection. Later on, the pain was localized in the right iliac fossa. Discuss the referred pain of appendicitis. So remember that in case of acute appendicitis, initially the pain is referred to the region of umbilicus. However, later due course of this illness, if it becomes a chronic case, then the pain is localized in the right iliac fossa. So remember that the afferent nerve fibers of pain sensations are being carried by the autonomic sympathetic fibers from T10 spinal segment, right? So the pain from this appendicitis is reaching through the dorsal horn to the lateral gray matter of the spinal T10 segment. While the somatic pain, the somatic sensations of the skin surrounding the umbilicus is being carried by the afferent nerve fibers running through the 10th intercostal nerve, and they are also reaching to the same spinal level via the dorsal nerve root into the dorsal gray matter. Since both the somatic and visceral impulses reach the same segment, and the somatic impulses from the skin around the umbilicus are better perceived by the brain, so the referred pain of acute appendicitis is at the site of umbilicus. Next is, where is the appendix likely to be located? As they've mentioned is that the pain was localized in the right iliac fossa. That means the position of appendix is such that it irritates the peritoneum and the structure surrounding to it in the region of right iliac fossa. And you know the most commonest position of appendix is retrocaecal or retrocolic. That's called 12 o'clock position. However, they have not mentioned, they could have mentioned to be more precise, that to check for the position of appendix being retrocaecal is ask the subject to extend the thigh. Because you know that this retrocaecal appendix is resting over to this muscle psoas major. So while extending the thigh, it actually gets irritated and causes the sensation of pain. Now this is just to remind you the another fact. The next common position is the pelvic position. That's 4 o'clock position. And that appendix is actually resting on the obturator internus muscle. So while medial rotation of the thigh, actually we do the reverse action. In case of psoas major, which is actually a flexor of the hip joint, there you have to test it by extending the thigh. Similarly, obturator internus is actually a lateral rotator of the thighs. You have to check it by medial rotation of the thigh. So in case of pelvic position of the appendix, pain will be aggravated on medial rotation of the thigh, while in case of retrocaecal appendix, pain gets aggravated on extending the thigh. So because of the last line that the pain was localized in the right iliac fossa, you can easily guess, and also because that retrocaecal is the most common position, you can mention here that the appendix is likely means you're assuming likely to be retrocaecal in position, located in the right iliac fossa. Then what is McBurney's point? You know that's a point for the incision to be given for appendicectomy, and that point actually is placed at the junction of the lateral 1/3 and medial 2/3 of a line joining the superior iliac spine to the umbilicus. So it doesn't mean that in a long question you have to write everything in detail and filling 5-6 pages. You can easily sum up this answer in one page only. You have to be precise whatever has been asked. So I believe if you know the answer to this question, you can maximally write all the answers within 5 to 6 minutes. Next, question number 2 is again write briefly on 3 questions of 5 marks each, makes it 15 marks. One is conducting system of the heart. This is a very easy and important question. You can read it from the book. Intra-splenic blood circulation. This I have taught you in detail. I believe you must have written it. And for those who are reading it for their upcoming exams, for the future batches, remember you have to write about the microanatomy, the microanatomic circulation within the spleen. I'm just going to revise it first because this is an important question. So remember, the splenic artery splits into around 5 segmental branches. Remember, in a spleen, just like kidney, there also are nearly 5 vascular segments: the anterior, the posterior, or you can say the upper, the inferior, and the apical or the polar, that's posteriorly placed. And in between there are avascular planes. And between the upper and the lower segments, there are also sometimes avascular zones. So that makes around 5 such segments. So splenic artery splits into 5 such segmental branches which enter into the spleen via the hilum, and then in the peripheral cortical tissues, it splits into various branches which run via the trabeculae of the spleen, and that's why they are called trabecular arteries. Through those trabecular arteries, when they reach towards the center of the spleen, they actually get surrounded by the macrophages, the reticulocytes, and if they're surrounded by T lymphocytes, they're called PALs, periarteriolar lymphatic sheaths. And if you take a transverse section, you will find that there's a central arteriole surrounded by a cluster of these lymphocytes. That also is called white pulp. Similarly, this trabecular artery, when reaches towards the center of the spleen, if it gets surrounded by the cluster of B lymphocytes, then it's called Malpighian corpuscle. This also will appear similar in transverse section with the central arteriole and cluster of B lymphocytes surrounding. Both these are grouped as white pulp of the spleen. Now, these central arterioles will further emerge out towards the medulla of the spleen, the core of the spleen, where they will be straight small branches, and those are called penicillar arteries. Now, those penicillar arteries will again be surrounded by free reticulocytes, free macrophages, even the plasma cells sometimes. And those are now called ellipsoids. These ellipsoids have 2 options to open up. Within the medulla of the spleen, there are venous sinusoids. Those are dilated venous pools lined by endothelium. And in between those venous sinusoids, there is the cord-like arrangement of reticulocytes, free macrophages, plasma cells, and these interpressed spaces between the sinusoids, these are called the cords of Bellroth. Because if the epithelioids, they open up here, the blood actually comes out of the closed circulation, that is outside the vessels, and regurgitates or runs here in between the spaces of the cords of Bellroth. That's why this cords of Bellroth is also called the red pulp of the spleen. And this makes it a part of the open theory of the circulation within the spleen. The other option, as I was telling, that ellipsoids might directly open into the venous sinusoids, and that is considered to be a closed theory of intrasplenic circulation. Because the exit channel means the blood, after being collected, will exit through the venous sinusoids, means the venules are actually coming out of those venous sinusoids. So the blood which was open up into the cords of Billroth will also now be collected back, or this blood from the red pulp will also drain into the venous sinusoids. And through those venous sinusoids, now the venules will emerge up and will follow a similar course as those of the arterial system, like, the trabecular veins. Trabecular veins will join to form segmental veins and will emerge out of the hilum to form the splenic vein. So that's what you have to describe here in intra-splenic blood circulation. Now, development of arch of aorta, this has been taught to you, so you have to write it. If you have not prepared, give it a reading from the book. Next, question number 3 is the ultra short questions of 2 marks each. There are 5 questions that makes 10 marks. First one here is posterior and inferior relations of the liver. Easy question. You just have to draw the diagram showing the posterior inferior relations of the liver and the visceral and peritoneal relations there. Because they have not mentioned is the visceral relations, that means you have to describe both the peritoneal and visceral relations. You can easily express it by drawing a diagram. Next is referred pain of cholecystitis. Remember that the pain of cholecystitis has been asked many times because the afferents from the gallbladder are being carried by 3 types of fibers: sympathetic, parasympathetic, and also by the right phrenic nerve. So if the pain of cholecystitis is being referred via the right phrenic nerve, it will be referred to the summit of the right shoulder, and that also is being innervated by the lateral supraclavicular nerve. So the dermatome there also is C4, and phrenic nerve also is carrying the pain sensation from gallbladder to the same spinal segment, that is C4. And as I have mentioned before also while teaching you about the referred pain of appendicitis, remember the somatic pain is assessed or appreciated better by the brain. In case the pain is being carried by the sympathetic fibers to the gallbladder, which are mainly through these greater splanchnic nerves and from C7 spinal segment. So the somatic pain of C7 spinal segment is actually from the skin overlying to the inferior angle of the right scapula. So in case of sympathetic referred pain, the pain will be referred to the inferior angle of the right scapula in case of cholecystitis, and in case it's being carried by the vagus, means the parasympathetic afferent fibers, then in this case the pain is going to be referred in the region of epigastrium. You can also draw it with the help of diagram. The next question here is derivatives of Mullerian duct. Mullerian duct means Paramesonephric duct, right? So it develops the female genital system, the fallopian tubes, the uterus, and the upper portion of the vagina. That are the derivatives of the Mullerian duct in females. But in males, it actually persists at the upper pole of the testis in the form of hydatid of Morgagni, and the lower portion of this duct which forms the uterus and the vagina, that persists in males in the form of prostatic utricle. Question number 3D, intra-renal blood circulation. This also you can explain with the help of a diagram showing that the renal artery, when it enters the renal sinus, it actually splits into 5 segmental branches, 4 running anterior to the renal pelvis. The one which is supplying the posterior segment reaches behind the renal pelvis into the hilum of the kidney, and from there, there were actually 5 segments, the 5 vascular segments of the kidney. So each of these segmental branches are actually end arteries. Then when they run within the parenchyma, they actually are running between the renal pyramids. The tissue in between the renal pyramids is called the renal column of Burton. So because they've entered the lobes, initially they're called lobar arteries, then interlobar arteries. When they reach towards the cortical tissues capping the pyramids, there they form the arcuate arteries. and from those arcuate arteries, they form the interlobular branches. Now, from that interlobular arteries, afferent arterioles are formed, which form the glomerulus in the Malpighian corpuscles. From those glomerulus, efferent arterioles arise, which form the arterial plexus along the nephrons. And then finally, the exit course starts because of the capillary meshwork around to the nephrons, which includes vasa recta, means the straight branches descending down the loops of Henle, and ultimately there are efferent venules, which actually will form interlobular venules, then arcuate venules, then interlobar venules, then lobar veins, and finally the 5 segmental veins will emerge out through the renal sinus to form the renal vein. So this also you can explain in brief just by showing all this in a simple diagram. Now question number 3A is achalasia cardia. As MBBS first year student, you just have to describe the anatomical basis of achalasia cardia. So as you know that the lower end of the esophagus drains down into the cardiac portion of the stomach, and that's why that's called the cardiac end of the esophagus, which normally remains closed and opens only while the food passes through it. As you know, there is no anatomical sphincter. But due to neuromuscular incoordination, sometimes it fails to open up. So what happens is the food start collecting in the lower end of the esophagus, and gradually it keeps distensioning and leading to dysphagia. That is called achalasia cardia. The distension of the lower end of the esophagus due to the neuromuscular incoordination. So this can be confirmed with the help of the barium swallow X-ray, where you will find that this lower end of the esophagus is dilated and tapering at the lower end. That is called the parrot beak appearance in an X-ray. Now the MCQs. Question number 1. Normally the position of umbilicus lies at which vertebral level? Upper border of L2, lower border of L2, upper border of L4, lower border of L4. So remember, it's the lower border of L1 which is called the transpyloric plane, and lower border of L2, or preferably the upper border of L3, is called the subcostal plane, and the lower border of L4 is called the intertubercular or the transtubercular plane. Now here they're talking is about the position of umbilicus. So one thing you all must be knowing, that the position of umbilicus in the median plane is variable, right? So whenever we talk about the position, we presume a normal, healthy individual and an adult. There might be sexual variations, there might be age-related variations, right? In children, then in adults, and even in people with pendulous abdomen, highly obese persons, the umbilicus actually sags down in case of pregnancy also, right? So actually there is a range for the position of umbilicus from L2 to even going down at up till S1 level. But ultimately you have to come to a point where you have to mark the answer. So according to the Gray's Anatomy, right, that is considered to be the referral book, the standard referral book of anatomy, the latest 42nd edition, they mentioned that this position of umbilicus on an average in an adult lies between the L3 and L4 vertebra. So if umbilicus, the normal position is between L3, L4, means here you can mark the answer as upper border of L4 vertebra. And remember, this plane between L3, L4, where you find umbilicus anteriorly, posteriorly also it has an importance, and that is the site for lumbar puncture, for giving spinal anesthesia, and also for CSF tapping. MCQ number 2, dartos muscle in the scrotum is a modification of. Remember that dartos is not a complete muscle, is actually muscle fibers impregnated in the fascia. So many times you must have seen that it's written as dartos fascia also. The options here are fascia of Kanpur, fascia of Scarpa, Colles fascia, continuation of fibers on internal oblique into the scrotum. So here remember that dartos is actually in continuation with the most superficial layer of the anti-abdominal wall, that is the fatty layer, and that also is called fascia of Kanpur. Remember, fascia of Scarpa is the membranous layer of the superficial fascia of the abdomen, which actually continues as Colles fascia, while continuation of fibers of internal oblique into the abdomen is cremaster muscle. MCQ number 3, arterial arcade is not found in duodenum, jejunum, ilium, eyelids. So remember, you have an arterial arcade found within the mesentery of jejunum and ilium, and even around the eyelids you find is a circular arcade. But in case of duodenum, you don't find such arcade. So the answer here is duodenum. MCQ number 4. Regarding celiac trunk and its branches, which statement is wrong? The trunk is only about 1.25 centimeter long. This is correct. Right and left celiac ganglion are situated on both the sides of the trunk at the same level. This also is correct. Now, these options are actually to make you learn and remember and revise your anatomy. Option number C is on the left, it is related to the pyloric end of the lesser curvature of the stomach. Then option number D is splenic artery is its largest branch. This also is correct. So option number C, where it says that on the left it is related to the pyloric end of the lesser curvature of the stomach, is actually the inferior relation of the celiac trunk. Remember, pylorus lies below to the celiac trunk, not towards the left. So as they've written is on the left, it is related to the pyloric end of the lesser curvature of the stomach. This is wrong. Answer here is C. MCQ number 5. Which of the following arteries is not a branch of anterior division of internal iliac artery? Middle rectal artery is a branch. They have asked is not a branch of anterior division of internal iliac artery. So middle rectal artery is its branch, obturator artery is its branch, superior vesicular artery is actually the proximal remnant of the umbilical artery. This also is a branch of anterior division of internal iliac. Superior gluteal artery is actually the branch arising from the posterior division of the internal iliac artery. Answer is D. Question number 6. Bronchopulmonary segments are well-defined sectors of the lung, each one of which is aerated by a separate secondary bronchus, tertiary bronchus, terminal bronchus, respiratory bronchiole. So easy, it comes into the definition of bronchopulmonary segment that they are well-defined sectors of the lung. Each one of it is aerated by the tertiary bronchus, which is also called segmental bronchus. The answer here is B. Question number 7. Artery to the ductus deferens is a branch of inferior epigastric artery, superior vesicular artery, inferior vesicular artery, internal pudendal artery. So remember that artery to ductus deferens arises from the superior vesicular artery, and from here this artery accompanies the ductus deferens and follows its course through the inguinal canal in the spermatic cord and reaches to the scrotum. In the same question, let me tell you another information because these arteries have some relevance. Inferior epigastric artery also gives a branch, and that branch is to the cremaster muscle. This also continues in the spermatic cord, that is artery to cremaster, a branch from inferior epigastric artery. This artery runs medial to the deep inguinal ring. An inferior vesicular artery, this corresponds to the vaginal artery in females. An internal pudendal artery is one which goes out through the greater sciatic foramen reaches into the gluteal region and then comes back into the pelvis through the lesser sciatic foramen and continues into the pudendal canal. Question number 8. Which of the following structures is not seen in a transverse cut section of thorax passing through the fourth thoracic vertebra? Fourth thoracic vertebra means the lower portion of the superior mediastinum. Remember, the plane dividing the superior and inferior mediastinum is the plane of the sternal angle, and that passes between T4 and T5. Here they have said that this cut section is passing to the fourth thoracic vertebra, means we're talking about the lower portion of the superior mediastinum, and they have asked is not seen. So arch of aorta will be there in the lower portion of the superior mediastinum. Left principal bronchus, this will not be seen because the trachea actually divides into left and right principal bronchus, that's called carina, just at this level. So left principal bronchus is actually present at the level of T5 vertebra. Left recurrent laryngeal nerve will be there because it slinks below to this arch of aorta at the level of this ligamentum arteriosum. Then superficial cardiac plexus, this also lies below to this arch of aorta, overlying to the left pulmonary artery. This also will be seen at the same level. Answer here is B, left principal bronchus. Question number 9. Perthes test for varicose veins of the lower limb is done to detect the competency of superficial veins, deep veins, perforator veins, valve present at the saphenofemoral junction. Remember that Perthes test is to detect the venous incompetency of the deep veins. For perforator veins, superficial veins, it is called Trendelenburg's test. Question number 10, the last MCQ. Lymphatic drainage of skin covering the lateral portion of the gluteal region is in upper lateral group of superficial inguinal lymph nodes, upper medial group of superficial inguinal lymph nodes, vertical chain of the superficial inguinal lymph nodes, deep inguinal lymph nodes. So this question is actually about the inguinal lymph nodes. So remember that the upper lateral group of superficial inguinal lymph nodes drains the outer or the lateral portion of the gluteal region, the skin of the loins, the flanks also is drained here. However, in the upper medial group of superficial inguinal lymph nodes, it's the anterior abdominal wall, the portion below the level of umbilicus, that is being drained here, including the genitalia, the superficial perineal structures. They also drain into the medial group of superficial inguinal lymph nodes. However, the vertical chain of the superficial inguinal lymph nodes actually drains the entire lower limb, the major portion. Deep inguinal lymph nodes, which is also called the lymph node of Cloquet or Rosenmuller, this actually drains the glans penis or the clitoris. So the answer here is A, and that's all in this question paper.